Thank you, David. And now I'll welcome Dr. Elaine Morano.
Hello, everyone. I'm Elaine Morano, and I'm delighted to have this opportunity to do this team science and translation because it really, from my standpoint, I get very excited on things that are around diffusion of innovation theory. And you all are at various stages of that diffusion, and there are thorny problems in the diffusion, and so that makes it very exciting. And I just wanted to provide a comment. I grew up in the Midwest. I lived in Colorado. And so when we think of distance, we think of time. We don't think of distance, right? So grandma, or mom, how long is it going to take to get to grandma? We say time. We don't say, or we say miles in the Midwest. We don't say time. You know, it's that. And so what you may be finding here is this is the implementation science side. What is the meta concept? Which is probably convenience or ease of getting to the health center. And maybe 10 miles is really good in an urban environment as dense as Chicago, in which you're taking public transportation. But 10 miles might not be a big deal in the rural environment. And I had a nephew who would drive every weekend for 8 hours just to go to do competitive volleyball in Kansas City. And so I look at that as, you know, how we think of it is different. And that's why it's so important, all of the different perspectives you bring, because the diffusion, you need to tailor it to the context that matters. How do we take the general learning and move forward? So what I hope to do is provide some frameworks. We hope that this is interactive, not just a bunch of theory. Fran Weaver, who's putting up things on the wall, we're going to have a break about midway in mind in which we're going to have you do some thinking around this. Fran is with the VA here in Chicago, Heinz VA. And for those that know, the VA has been a real leader in implementation science. And then after lunch, we're going to be breaking into small groups, and I'll introduce some of the team members from Loyola. We're all part of the Institute of Translational Medicine's Implementation Science Cluster. So it's really exciting to be able to work on projects like this. A little background on myself. The first half of my career, I was more in practice. I worked at Procter & Gamble. Developing and commercializing over-the-counter prescription medicines. And so when I get to my example, I'm going to use Crest toothpaste to extend what you were saying and how we think about implementation and what's the value proposition of what we're trying to diffuse. Okay, so this is just to get you thinking and through the lens of implementation science. For some of you, you may already know all of this. For others, for you, I'd say just how do we start to think of applying these concepts to CCP? For others, this might be new concepts. I'm going to give you more of the theory and frameworks, but close with more of the what does this really mean in a pragmatic sense for the questions for us in the conference. But from an implementation, we think, what is the program? So that was why it was very important how David was describing what is this actual thing we're implementing. Where are there areas for adaptation and flexibility, and what are the core elements? Where are we in this diffusion process? So I get excited when you think about scaling and trying to bring an idea to broad numbers of people. But it's also important to know where you are locally. And I'll talk a little bit why, because the kind of evidence that's needed starts to change as you're starting to work with those that are the visionists versus those that are later in adopting. And you need different evidence to convince. And that is where we get to what's the value proposition. And David hit on some of them, and we're going to get us thinking a little bit more. That's what the things on the wall are. Many of you are thinking pragmatically, how do I make this happen at my local site? And how do I actually get over the tipping point? If you read Malcolm Gladwell's book, it's really a diffusion of innovation theory. And it's natural chasms as you go from innovators like you are, visionists, to actually real world pragmatists and those that are saying, I'm looking for convenience. Okay? So why do we, some of this is overlapping a bit with what David said, but the Institute of Medicine is the 17 years. But we know this in everything we do. We are humans. About half of clinical practice guidelines are actually adhered to. we know after a year or so, half of patients are still complying with medication like antihypertensives. But it's not just in the medical sense. This is true for if you're a company and you're just trying to be a startup and get your new idea out there. 3 out of 4 startups fail. So the very thorny challenge of translation in 100 years is because a lot fails, and that's the headwinds that we're working through. And David mentioned, as it relates to the valleys of death and how that relates to things that we do academically too. So I won't repeat that. But this is interesting. Why do things fail? It's because they're making products no one wants. And we might say, well, golly, what we just heard is very important, right? It's going to save things. But if I'm an adopter, I also heard of a health system, and that's not solving a problem I see right now. It may be your problem, patient, or you provider, but if it's not the payer's problem, then you're creating something I don't really need, right? And so that's the chasm we've got to get over. It's like, how do we think about the value of this program for all of the, I'll say, P's, provider, patient, payers, program managers, such that they're all seeing value in this, and it's helping to solve a problem for them. And that's, I think, partly because our challenge in academic medicine or public health is that we get good at writing things for funders that are looking for innovation, significant statements that are often framed at a population level, right? What's the prevalence of the disease? What is the incidence? How many people die? It's very population-based. But when we think of our own adoption, it's a very personal one-on-one decision. And so that is the translation of how do we think of the value to society, but the value to the person that's needing to adopt, knowing that they have different day-to-day problems they're trying to solve. That's our translational challenge for ourselves, is crossing that communication chasm. And that's because, as we all know, I just picked one study here, clinical inertia, any inertia, it's easy to stay with currently what you're doing. To try something new and ingrain it into your new set of behaviors and habits takes intentionality. And whether that's a clinician, a patient, or a healthcare system, inertia is a very strong factor. So you almost have to demonstrate an activation energy such that you overcome the inertia and get people to adopt. Okay, so that's where implementation science as a practice aims to address. We are scientists that care about what are the strategies that we can do to cross these behavior change chasms. Okay, so sometimes it's referred to as dissemination and implementation science. Dissemination are strategies to spread knowledge. There's scientific dissemination, like very important papers, but there's also dissemination you might pick up at a conference or a word of mouth in a local community, CME event, etc. It's thinking about that mix of communication and how do you raise awareness. Think of that as our advertising. How do we advertise? Second is implementation. What are the different strategies now that are needed to promote adoption, whether that be at an individual level, organization, or community level, so that we actually use that intervention, that program, and then want to sustain it. So different set of strategies, and that's what we're going to spend a lot of our day today is thinking about what you've already learned are effective implementation strategies. Where are you seeing key barriers that need to still be overcome? You can think of implementation as the marketing, right? So we need to advertise, make people aware, but we also need to come up with marketing strategies so that people are buying and rebuying, okay? So you'll see me use kind of some lay business terms, and I kind of go back and forth. I'll share one that was the CEO at Procter & Gamble maybe about 20 years ago, who talk about adoption when you're buying something as 2 moments of truth. The first moment of truth is when they purchased your product for the first time. They were compelled that it was an interesting concept. I'm going to try it out. The second moment of truth is they repurchase. That means they had a good experience, and we might say they're going to sustain and maintain what you're doing, right? So you are all dealing with those moments of truth, right? Some of you are at that first moment of truth. I need the site to first start, let's try it out. And then the second moment of truth is, why are we still doing this, And that's different evidence, that's different strategies and different communication. So what we're trying to do in a plan of designing for dissemination sustainability is think of this in a holistic, you're going to have these moments of truth. Am I getting evidence that's going to address all of this so I have a comprehensive evidence package? And I thought the way to walk through this so that you're also getting a little bit of a great reference. This is a paper that was written by Enola Proctor and team from WashU in St. Louis. They have been really the innovators a lot in the methods in the area. And this is a fantastic paper if you're just looking for 10 tips or 10 ingredients for success if you're writing an implementation science grant. But it will give you the key concepts of what implementation scientists or translational scientists are looking for. Okay. So the first one is, can we clearly articulate what is the quality of care gaps that exist? Like, what's the so what? What are we trying to address? You're all here because we all agree that continuity of care, healthcare is fragmented. That's the gap we're trying to address, right? But it's really clearly articulating that. So what's the evidence to support it? So I would say check. This has been well demonstrated. The second one is, has the evidence for that program, treatment, or service been demonstrated and justified? All right, so I would say the evidence that you've shown is coming from very high quality. It's randomized trials. It's real world practice. That is the proof of concept that gives us the efficacy in real world settings that says there is something here worth adopting. Now, really hardcore implementation scientists would say, if you don't have perfect evidence or you're not ready to implement, don't implement something until you've really had it. It'd be like saying if you don't have FDA approval on a drug, don't disseminate it, right? There are times, though, in public health, I'm a public health person, in which you can't just say, well, let me wait. Like with COVID, we can't wait until we have perfect evidence. We have to implement and learn in a learning health system way, right? But if you're writing a grant, you have to at least acknowledge what is the evidence and the justification for going for it. But you have a wealth of that, so that's not, I think, an issue here. The question is a little bit of what is actually being implemented and where is there heterogeneity in that. When it's, let's say, Crest toothpaste or any drug, it's very clear what that is. You have a dose, you have how it's delivered, exactly if they took their medicine, you can even measure it in the blood, and I know, did they comply, right? That's a very defined intervention, right? So we have to think through in CCP, what is at the essence of it that is the equivalent of the daily dose, if you will, for a program. And we've had a lot of discussion around that, and I think that's further discussion, really, and discernment. Who is the target patient population? Who is this indicated for? We talked about, are they dual eligible or not, distance or convenience or not, etc. That is who's the indicated group. We've talked about they're hospitalized past 2 years, or they were in an emergency department. Is that the consistency that would say this is the target drug indication? We've talked about that there's a core element, it's intentional in-hospital and ambulatory continuity of care. That's my words. But it can be accomplished in different ways. There's different models. One hospitalist, one in primary care is the same person. You have partners, you have teams. Where is there flexibility and where is the non-flexibility? We talked about that the program is more than just continuity of care, it's connection with social services. That's recognizing that there's probably social determinants of health that are very much at play, that are affecting health outcomes. And so there are a variety of ways that also is being delivered. Where is there flexibility? Where is there the need to tailor it to your local context and environment? What is at its core? This is the implementation science piece, because if it goes forward with a large trial, you're going to have to make that pragmatic decision of how controlled you make it and how flexible. You might say in a rural setting, the connection to social services is through religious organizations that happen to be in that community. It might be different in an urban setting, but really the core here is connection with social services. Okay, so that's how we think about what actually is the intervention. What program are we scaling? And we'll need to be clear on that for this as well. Okay. Implementation scientists love lots of frameworks. There's probably, I think, last count, like over 170, right? In medicine, you say, what's the unifying theory of how the disease is operating? And I think in behavioral sciences, people are constantly fine-tuning and putting their name on it. But this is a great framework and to get us thinking about adaptation and modification so that we're intentional about it. We understand, is it 10 miles that's special, or is it time to get to, or ease of getting to? And if that's the core element, how are we adapting that definition in different contexts? So as we go through and listen to different case examples, this gives us an implementation model in which to summarize. And so that's a little bit. So we might say, what is modified? The content, the context of how it's delivered, what training and support was given to the professionals doing it, different strategies, and you're trying to understand the adaptation. Why? Why were we making those adaptations? What was the goal? Was it to increase patient participation, make it easier, fit within your workflows? Are we trying to improve effectiveness or reduce cost, et cetera? So part of this as a natural diffusion, experiment that you all are doing is capturing the wisdom of the crowd of what you're already doing and getting some categorization and understanding how you're adapting and why so that we learn from it. Okay. I do work in drug development. My area of specialization is post-marketing safety surveillance. We're constantly looking at how prescribers are using medicines in new and novel ways, learning from that, and sometimes companies will actually go through the process of getting a new indication, right? That's because we're seeing how in the real market things are being used and adapted. You all are doing that real time with CCP. And so part of the implementation science here is capturing that and learning from it so that we can adapt and spread those good areas. And also say, what are the things to avoid? Someone tries it and it doesn't work, right? Okay, so a big area in implementation science is that you find a framework and you think about a framework of the behavior change that you're doing. I think the one I like a lot, particularly when you're dealing with lots of groups here in different disparate areas, is we have a diffusion of innovation opportunity. And so diffusion of innovation theory talks about what are the characteristics of the innovation, the program itself, how we're communicating it to build awareness and persuading adoption. So that means we should be thinking about what is awareness strategy, but the adoption strategies are interpersonal. It's through the connections of people that we are persuaded to try something, not just being told to do it at a conference. It's time-based. That's the 17 years, but we can predict it, and so therefore we can shape what we might anticipate, so we're ready with the right information. And it's a social contagion. Okay? The social contagion means that we start to think of each of you as key opinion leaders that is learning and sharing your experience with others. Okay? And you might not think of yourself that way, but you're at this conference, and so you all are innovators, you are early adopters, and you are key opinion leaders, right? So you start to think about how you capture the wisdom of this kind of event and start to share it with the next crowd. Pharmaceutical companies think very clearly for anyone marketing. They have international key opinion leaders that are driving the science of how do you do a trial. They have national opinion leaders that are going to be very important for pricing and reimbursement and local formulary decision making. And then they have local opinion leaders because local people trust each other, right? And there are intentional marketing implementation strategies for each of those levels. Right? So it's starting to think about ourselves in the same kind of way. Because we are humans also operating in social networks. And that's really where diffusion of innovation theory comes from in a very simple way. It started with looking at the social behavior of farmers who are adopting hybrid seed corn in the 1930s. Lots of seminal work. In the 1960s, there was a key study that looked at the adoption of tetracycline for the first time. And so this has been really codified and shown that you have in a natural setting people who are more excited to be early adopters. We'll call them visionaries and enthusiasts. And they're excited about trying it out first. They're dream realizers, they're evangelists, they're comfortable with taking risk. I bet you all of you here fall into that category. And then there's the mainstream adopters. I'm from Missouri. I'm from the show me state. Show me. How's this going to really work in practice? That's what you did at University of Chicago. I don't know if it's going to work in my setting. And so they're looking for pragmatic, ease of use. They're going to jump in when they see that there's a critical mass doing it, right? So you have to think about this. The laggards, which, no one wants to be a laggard, but sometimes people lagging is okay. Like there are people who are saying, I'm not going to do that. I'm not going to adopt that new drug therapy until I know it's been used for a couple of years because I want to really make sure the safety of the product is really good before I'm going to adopt it, right? So laggard's not always bad. It can be intentional because they're looking for some other information in order to convince them to adopt something. So we have a natural experiment here. We were trying to understand from you all where you are in your stage. We have innovators here, David, Meltzer, and team. We have early adopters, and we have folks that are probably maybe in the early adopters considering it. They're that bridgers, their propensity to adopt, but maybe haven't done it yet. And you're encountering hurdles, implementation hurdles. And that's what we're trying to understand, learn from you. Because this is a more updated version, this is looking at the crossing the chasm of technology, Geoffrey Moore, and this fits with the tipping point. And that is, there's early markets are really excited about new things. Academics, what do we get rewarded for? New things, innovation. We have to write an innovation section on our grants. Who wants to do something that's not innovative, right? But the real mainstream, the population, are looking for practical solutions. And so it's that chasm or tipping point that's what we're trying to overcome. Help with the adoption of the visionaries that you all are, but gather the evidence, the teams, the people around us, such that we are also providing the evidence for the early majority, right? So that's how you may have come here just to learn about your own site and what can I learn for tips. I'm the implementation scientist, so I find this a very interesting natural diffusion activity that's going on. So we'll make sure the rest of it is like how you walk away with something that's tangible for your own site. But I think it's interesting to see where are you in this 17-year journey, so to speak. Okay. That's because we also need to, do we have a clear engagement process of the stakeholders in place? Okay, so it's common to say we have physicians, clinicians, nurses, social workers, the clinical team, and we have patients. But the stakeholders are broader than that, as we all know. This was a framework I had a chance to work on. It's not magical, but it's a good reminder of who are the stakeholders that affect adoption. It's the patient and public, it's providers, but it's those that are purchasing or paying, policymakers, product makers. In our case, could be other healthcare systems or other innovators, telehealth innovators that are trying to solve the same problem, and then other researchers, right? So that's how we might think of it in a patient-centered outcomes research. If we were a business entrepreneur, we might say, okay, here, who is the user? Who is the influencer? Who's the recommender? Who's decision makers? Who's the economic buyer? And who's a saboteur? right? And why do we think like that? Because this is now starting to think about, I have to influence individuals, not collection of stakeholders, but actual individuals within my system, okay? And a saboteur could be, you know, I'm not going to say this eloquently as you, David, but, you know, the health system payer might say, okay, we're retaining the most expensive patients. Is that really what I get rewarded on? Maybe not. So I'm going to be dragging my feet on this decision. In fact, I might even put up some roadblocks for you. That's what we mean by a saboteur. They're not doing it to be evil. They have different incentives. And we have to understand what that is and do that. If we were in health policy, you do these little force field diagrams and you say, is this one for a policy? Is this one against it? Is this one neutral? And you're trying to get your negative people to at least neutral, right? You're trying, you know, and so you have strategies by which you go about doing that. And that's what we've got to think of too. How do we communicate our value of this program to various folks? So we in the ITM are part of a national group. I know at UChicago they have I-Core, Innovation Core. It's training that's helping academics think of their innovation in a way that traditionally was developed for NSF and commercialization. So I'm going to do it like a tech transfer kind of thing. We've adapted it for implementation science because at the very core of things, people are adopting. And we're going to have you think about it from the standpoint of who are your individuals? What are the jobs they're trying to do? A patient, a payer, a provider, a program manager, a policymaker, or a hospital leader? What's their, what we'll say, pants on fire problem? What keeps them up at night? How does CCP solve that problem? Can it? What is their aspirational gains? What motivates them? Sometimes health systems are motivated because they want to win quality awards. Or sometimes they're motivated because they want to be a leader in the nation, be the first to be doing, these innovation awards. Sometimes the gain is, some other emotional thing in which someone's wanting to demonstrate a program's effectiveness so they can get promoted. That's a very human thing. So what you're trying to do is understand what really that is. So we think about CCP's value as gain creators, pain relievers, and job solvers. Okay, how many of you feel like, wow, that's a little weird? Language? Usually people like, oh, damn it, Elaine, that's weird. No? Okay. We did a survey, and that's what David was talking about. But essentially, this is an implementation science hypothesis. For each, our CCP helps who? These are the customer segments, helps patients or payers. You might further segment and say it helps providers who are operating with a high degree of Medicare patients, who want to do what? By doing what? Reducing or avoiding a pain for them or getting a gain and delivering a benefit. Unlike what? Which can be doing nothing. Just keep doing what you're doing. Okay? Sometimes you have an alternative that you could adopt, right? Some other programs trying to solve this problem. Okay. So what we did on the wall, some people did our survey and did some draft value propositions. Okay. On your table are our little stickies. And so we're going to take a 5-minute here where choose one of these groups that most resonates with you. And as you know and reflect on CCP, choose one, and can you write on here what you think patients really want, and what is the CCP delivering for them, unlike what else they could do? Okay, so maybe take one group and 4 stickies, okay, and take a moment and say, what do you think is really motivating here? I'll keep this up, and I'll give a tip. All right. So the fluoride, I will use the fluoride example. I worked at Procter & Gamble, and the first place I worked was the oral care division. So I think it's really kind of interesting that you chose fluoride, right? So this will date some of this. Some of you may remember the early Crest advertising, look, Ma, no cavities. Did some of you remember that? Okay. All right. We could say the value of Crest toothpaste for moms, because they were the economic buyer for toothpaste for their family back then. The value is you will have and I don't know what the clinical number is, but I'll just say a 50% reduction of caries for your child that's the age of 3 to 6. And you go, wow, that's nice. Now, would that motivate you to buy a product based on a caries, clinical score? Maybe. Or you could say for moms of children 3 to 5, their child's first dental visit is going to be a success, such that they walk away from that dental visit proud with, look, mom, no cavities. And they show that mom, look, mom, no cavities. The benefit to the mom is, what do you think? It's an emotional benefit. I did my mom job really well. My child's first visit to the dentist went super well. The child is happy. I'm going to get that child back to the dentist again. And so I feel really proud of my mom job, right? And so we are clinical data people. And so we sometimes talk about the functional data. Try to put yourself into the emotional state, right? And maybe for some of you, it's the providers will be easier because I know many of you are physicians. What is the emotional value of the CCP for you? What is it really doing? Is it the collegiality? Is it, I get to work with a team. This is why I became a physician to begin with, or a social worker, or a nurse, whatever. That's what we're trying to get at. That's the value that the promise is delivered by the proof of concept, the data. But what we're trying to say is, how do we articulate really what's the exciting reason? Okay? So there are no right or wrong answers. Just let's take 5 minutes for you just to think about one of these. And if it's only one sticky, that's fine too. We'll put them up at lunch. But this will be something we revisit tomorrow. Okay?
Color doesn't matter.
And the color doesn't matter. You can write with crayon or you can write with pen, and it can be just one word. You do not have to write a thesis. We'll give you 5 minutes.
Can I ask a question?
Oh, question, yeah.
You don't have to be the provider. We can choose any
You
category.
can choose any category, whatever speaks. So we were talking at your table that you deal a lot with patients and trying to get your head in the mind of how they're thinking.
Yeah.
So the idea is to be the empathic, walk in their shoes.
So we're gonna so the R is gonna be CCP for everyone, kind of, and the helps is gonna be patient, payer,
Yes.
provider, program manager, or policymaker.
Yes. Okay, you guys have done just wonderful. Thank you. What you are doing are hypothesis statements, right? This is the value hypothesis that we need to synthesize, collate, validate. That's the discovery process. And in some cases, we might find, maybe David, are you measuring emotional well-being of the healthcare system team being part of it?
We're trying, subject to the constraint that there are only 4 or 5 of them, and
Yeah.
that makes everything completely, totally identifiable.
Yes, and also they self-selected into the program by participating in this.
And I'm good with that. I'm not yet ready to randomize people to jobs.
Yes. But that's where you start to think, okay, if that's really what excites is like, this is why I went into the practice of medicine and clinical care. How do you start to, can be anecdotal stories. That's the testimonials, right? It can be very
What is the
powerful.
value proposition for?
All right, I know UChicago is a leader in cancer care. What kind of TV ads do you see for cancer products? What are they usually showing? If you watch TV anyway.
They're not the other thing. This is the obesity product.
They're not, okay. What are they, all right, if you pay attention to them, that 6-month extended life on average, which I think is what many of the products are, that's the evidence. I can get to my grandchild's graduation. I can get to that wedding. I can make it to that life event that's really important. That's an example of how you can't say that if you don't have the hard evidence, But what's selling it, the idea of it is that I want to be at those in meaningful, important things in my family life. Even if I know my longevity or prognosis, I just want to get to that next life. You know, so that's our challenge, you know, because we're not necessarily commercial advertisers, but that's kind of where we're heading here. And so this is some of the things I heard from you, David, earlier. Relationships matter, knowledge, trust, whether that be the patient or family or, you know, care. I know my father-in-law, before he passed, would probably have qualified as one of these high rehospitalization. He had probably 10 or 12 different chronic conditions. And getting him into one health system so that at least there was coordination of medical records and that provided not just benefit for him and his wife, but the extended family, because at least we knew that he was getting the best coordinated care we could get, right? And so there are these other kind of like, you know, benefits as well.
Yeah. I mean, just to share, I mean, when we do recruitment for CCP and we talk to families, you know, we're talking to them about how this is not just good for the loved one, but good for them. And we actually do couples randomization, where if your spouse is eligible, we'll bring you both in together.
Yeah, and then there's a spillover effect because yeah, you know, it's I did some work with antipsychotics, and so I'm curious about how many of the dual eligibles have serious mental illness indications, but
I can answer that.
Yeah.
Many fewer than you would think.
Yeah.
In our population. And that is partially because we don't provide optimal access.
Right. So it's a very select dual eligible, because in the mental health side, dual eligibles kind of a different, when people hear that, they're thinking.
Yeah.
But, what was I saying about? There was a long-acting injectable drug, and they were trying to understand what's the benefit. They hypothesized if you stay on your medicine, you're less likely for hospitalization and emergency department. And what happened is the hospitalization didn't really change, but the emergency department did. And so the hypothesis early on was that maybe it's the fact that you had to come in and get a shot every month, that you now have that care interaction that you didn't have before when you were just prescribed an oral and you just kind of disappeared. And it was really, that was the mechanism was through the human interaction, right? So it plays out.
This is, by the way, one of the stories that obstetrician gynecologists use to argue for annual pap smears forever, despite all sorts of evidence that they, in fact, weren't valuable.
Yeah. It forced people to, come in. At earlier ages, right? You know, I mean, okay. So this is, everyone gets slides. We will go through this tomorrow, so don't worry. And, you know, some of this is what David was saying. These are hypotheses that we need to coalesce around. And so I'll just put a thing. Because you're part of this, we put on training. Many of us here are trainers, Teresa Burkhart, which we'll introduce after lunch, in this. And it's not just for CCP. If you're kind of intrigued by this for your own intervention or idea, you can be part of our training in which you kind of build out your hypothesis and you learn the skills in doing the interviewing to kind of validate. So if you're interested, you can talk to any one of us at Loyola. Okay. We're all bought in, there's value here. Many of you came because you wanted to get to the implementation. This is what we're going to do after lunch, which is now thinking about implementation strategies. Where are the barriers, the hurdles? How do I adapt? And there are different strategies, predictable problems, anytime you're trying to do an adoption in a healthcare system, that we can rely on from implementing science. I wonder if maybe you just present through it after lunch when we give people the task. Is that good? Yeah. This is going to be what you work on at the lunch break and after an early afternoon. And that's a framework readiness tool where you start to think about systematic questions, what's going on in your hospital, clinic, human resources, what stakeholders, social needs, and finances. Some people are linear, and questions are very helpful, and some people are visual thinkers, and they want to see the holistic picture. That's what this pretty diagram is, and that's thinking about where are the red zones, for those that are not colorblind, the red zones at the bottom are the areas of the pain points that you need to work on. So we're going to think about that in your own individual settings, because that gives us ideas for strategies that you can then test. Okay? And then, it's testing them so you're conceptually justifying them. It's not just saying, hey, let's try this out, but it has a conceptual model, et cetera. And again, implementation scientists love models. And so this one is showing diffusion and innovation theory in the context of health service organizations. Another framework that comes from the VA is the Consolidated Framework for Implementation Research, CFIR. And it's really getting us to think systematically what's going on within the clinic, in the hospital, the systems and the innovation, et cetera. So each one of these, we're being intentional around a strategy. Okay. And then importantly, do we have the right team training to make this happen? So tomorrow morning is a discussion around the team training, experience, and process. If this goes forward in a large pragmatic implementation study, you start to think about, well, how much do we make it just real worldness? And how much do we control how the training and the resources is or constrain it? It's kind of like in a drug trial, you have eligibility criteria in a study, and you go, do I exclude all of the people who, had all of these prior conditions, and so I'm really getting healthier people? Or do I open it up to everybody and I don't care, on what? That's the pragmatic trial aspect that has to be thought through. How much expertise is needed? Why is this important? Well, you obviously want the study to turn out. And so control allows a more homogeneous ability to test. But if you remember the diffusion of innovation, the middle group, they are like, is it going to work in settings like me? And so if you choose settings and too many constraints, then the middle go, well, gosh, it worked for you, but it's not going to work in my setting. I don't have X, Y, and Z. And that can play out like in an electronic health record system, right, in which everybody in the community is on the same system as my hospital, et cetera. That's a very unique environment, right? And so you have, that's what goes into the study design, right? And how you think now about the methods and the questions. So it's also thinking of the continuum of the testing, and this may be where the group decides to go next. Once you show efficacy, you now okay, I need to look at the implementation process. There are different types of hybrid trials on this continuum in which, type 1, you're just trying to understand implementation barriers, which probably have already been done. Type 2, you're giving it same weight. I'm looking at effectiveness as my primary aim, and I'm also looking at implementation strategy, feasibility, equal weight. And by the time you get to the third side, you go, I already know it works. I'm just going to, measure it. The primary aim is really the implementation strategy. And that's just recognizing that, as we do evidence generation, we're at different phases, and therefore different questions make the most sense in different parts. And really, is the evidence there on how to cross this chasm, as I said. There is another framework for pragmatic trials called PRACES 2, and that is getting to think about all of the things that go into a study design and how pragmatic or efficacious. Like, is it going to look just like an FDA quality study where it's so tight and narrow, or are you going to make it a real world simple trial? And how do you think about that as the patients you're recruiting, the settings it's occurring, how it's being delivered, what follow-up's occurring? There will likely be intent to treat, but what per protocol analyses, et cetera. So this is another thing as it goes forward, if there's further evaluation, thinking about this, again, because the evidence you're generating is helping in that next diffusion process. How is the program going to be evaluated? Tomorrow, Fran Weaver is going to be walking through other kinds of endpoints besides just the clinical kind or economic kind that are useful in this regard. And then you think about what those are, just like with any trial, how do they line up with the implementation theory or questions you're trying to evaluate? And this is what Fran will walk through tomorrow, another framework. How many of you have heard of REAIM? Yeah, so REAIM, Russ Glasgow and team, reach, effectiveness, adoption, implementation, and maintenance. Very easy, pragmatic to think about any evaluation. PRISM is just now adding on context, right? How do we understand the context, right? And that's why it's so fascinating. You all are coming from different context settings. And how do we understand that infrastructure, policies, strategies, and really evaluating the effectiveness of the implementation of the CCP. And last here is, would the proposal address how the initiative aligns with policy payer trends and priorities and issues of sustainability? So we're very fortunate that you have an economic training because most projects don't include economic evaluation or cost evaluation to the degree which you have. So you're already ahead of the game on this because you're already thinking about policy and how are payers, how does this get reimbursed, how does this relate to the bottom line for the health system, et cetera. That's just making sure that, implementation people are thinking that too. Kaiser has been a real leader in real leader in this, in making sure that, economic, what's the cost of delivering it, but also what is the financial effectiveness of the intervention. So looking at budget analysis as well as cost effectiveness, because who looks at budget analysis? The person who has to say this is going to affect my budget. I don't care what's the societal cost effectiveness ratio. I manage this budget and I need to make sure that, from that standpoint, whether it's a formulary or whatever the budget they're managing. So both sets of information are important. Okay. And again, it ties back to the value proposition for some of these P's, if you will, as customers. This is quite important. So what we've walked you through, and this is the program that we are have developed at Loyola Chicago, and it's a book chapter and it's a paper that you can reference, there's science to this, is thinking about this from begin with the end in mind. The more, and I know you guys aren't at the beginning, you're somewhere in the, you've done it, you're learning, it's an iterative process. But it's this idea of, do I have a really good understanding of the problem and solution fit? Do I understand my market? What's the setting or the types of hospitals or types of patients where this works most? And business model fit is who's going to buy and sustain it? How is this financially going to be sustained? Okay, so we're trying to bring in these sort of business concepts into a conceptualization, design, dissemination, and impact analysis framing, which is kind of the language we tend to use in our own academic. And that's what we're trying to bridge through the programs, through the ITM, is bringing business insight into the thorny problem of designing and scaling and sustaining health innovation that may not be commercial in the same sense. Okay, so I'm going to finish on time, which is good. So now we're the same questions, but drilling down in a pragmatic, concrete way for your own site. And that's where we're going for the rest of the conference, is that the talks are going to tie us back to some of these key questions. What are the program elements of CCP that you're implementing or considering implementing? What is your local value proposition? You're thinking about your local setting, what drives the various players, actors, economic buyers, decision makers in your local setting. What do you think is your own implementation readiness? And that's what we're going to do with lunch. And then we want you to be thinking about, as we hear the different ways around care coordination, we hear the different ways around the social service integration, and we're going to be talking about workforce. What are the strategies we can learn from one another that might help your local setting, right? So you probably, I hope, came here so that you can learn. And so we want to make sure that there's cross-learning, because something going on in Wisconsin could really inform, Chicago or the Kaiser setting or another setting. It's like, how do we, this is what enthusiasts are in the diffusion. They come to conferences like this to exchange ideas. So we really are diffusing the idea just by even being here, so that we can think about strategies and catalysts. And by coalescing around this, we also are getting greater clarity of what is the intervention that might be scaled further and evaluated. And some of you may be interested in that component too. Okay, so I did a lot in an hour. We're touching on concepts. We're trying to be pragmatic. It's grounded in theory, but we're applied implementers here. And so, the things that excite us as translational scientists, you want to make critical care better. So before we break for lunch, are there any questions or observations or comments? Yeah.
I'm Francis. I used to work in academic, and now I'm in for-profit. I'm with Cigna. So I think the only thing that I kind of would point out is sometimes being a saboteur isn't a bad thing. I had to change my mindset because at Vanderbilt, I hated the saboteurs. But here at Cigna, the saboteur because you want to make sure it's the right clinical thing. So there's always going to be a tension, but just making sure that it's okay to be a saboteur for the right reasons. I think that's the key thing.
I'm so delighted you said that, because it's very easy to sit on one side and then vilify the others. Customer discovery means you walk with empathy and you listen, because you have real problems at Cigna that you're also trying to solve, right? And you have real jobs to be done, incentives and aspirational gains. So it's not going to work unless you're providing really, healthcare is so multi-sided value proposition. We need to have flow with all, and to be open like an entrepreneur is to how do you show value in your setting. So I'll put you on the spot. You represent the payer, I'll just say the payer side. Where do you see the value of things like this from your side that you hadn't realized when you were on the other side?
So the payers need this, and I think strategically that's why Cigna wants to get into this, and they're ahead of all of the other payers. So compared to Vanderbilt, where I didn't have access to all financial information, I could see it now. The challenge is they don't have good clinicians. So it's interesting when you see it from both sides. That from the Vanderbilt side, there's not a lot of business, acumen, and here, you don't have a lot of good clinicians. You don't have, So it's interesting to see that dynamic. But I'm in spaces when you'll really see the incentives are horrible, that it's financial, and it scares me that, is this how it's going to be? And that's why I think it's good in this room that we have, your voices in your own groups, because I think the future of how healthcare should be, would be in this group, right? Because, it's when I see it from just on my financial perspective, that's what they see. So I have to be that saboteur to kind of say, hey, no, that's not how we do it.
So we have to be very savvy with the finances
Yes.
and the economic incentives
Yes.
of the people
Yes.
that are going to be paying.
Yes.
I'm curious, a hypothesis I have is, does an insurer care about, like, if there's lots of churn of physicians or
No.
care providers?
No.
Yeah, so retaining or satisfying, not important, yeah. So this is what, it's hard to hear, we want to like, what? But a hospital might, or a healthcare system might, because it is costly. So it's really, how do we listen to each one of these with that little mindset? So David?
I just
Yes.
wanted to share too. Thank you, Francis, for outing yourself. I don't. I think your comment's really, really important, and I have two sort of complementary thoughts about it. One is that there may be environments in which payers don't win in this, but there may be environments in which they do. And maybe one of the things we can do is help payers identify that they happen to be in an environment where they can win and get them to do it. And then that brings me into the second strategy, which is that payers, at least to some extent, exist within a set of rules determined by a set of forces above them. And although we know that, payers influence policy, we also hope at least that policy is made based on another set of principles that is not just totally driven by the payers and captured by that. And sometimes those policies make sense, and sometimes those policies are not optimal. And sometimes in those circumstances, it becomes necessary to advocate for policy change. And I think that we may be in a position with CCP where both these things are true. That there are probably markets where a payer, Cigna or whoever, could do really well, and we say, hey, you could do really well in this market because of it. And here's the other benefit of you doing that. That I want you to know we're going to go try to change policy. And if there's ever a time in American history when every policy is on the table, it seems like it's right now. Okay? And then say to them, if we are successful in changing this policy, then the kinds of stuff you're able to succeed in right now in this environment could be potentially successful everywhere else. And you could be the very best in the nation in doing it, and you can become, the biggest, most profitable, most successful.
Right.
So, I don't know if all that makes any sense, but I think we need to come up with a set of narratives that is responsible. I mean, the other thing I guess I'll just say is, I'm amazed what doctors will do for a donut. I am amazed what hospital executives will do for a ranking.
That's the social emotional benefits.
Right. And so, I think we need to, and I'll just say, we have some patients in the room, and nothing is more compelling than hearing your stories about how this has helped you. And I think we need to open that front in this, because I think it has the ability to move policymakers, and they have the ability to reset the rules, which makes it possible for everyone to do the things that if you ask them as human beings, they would want to do. But right now, they're not incentivized well.
So, and this is a perfect articulation of coming up with a designing for dissemination sustainability strategy. It's recognizing it's not one size fits all. It's being intentional as to where is the greatest value. In the business side, you might say beachhead market, show value there in an area, and then you build from it. And it also means you need a comprehensive strategy that includes policy or other kinds of components. It's not just and here's the clinical information, and that's why you think of this as a larger strategy. It's a commercialization strategy, right? It's a diffusion strategy.
Hey, just one other quick comment. I think that we could do so much more to tell the stories of our patients and get them out there. And I just want to say that out loud because, I know at the U of C, there are institutions like the Neubauer Collegium, which fund humanities-oriented efforts, humanistic-based things. Someone should do that. And there are, I think, there's the Gold Humanism Society, that's nationwide. There's probably a whole variety. Joyce has let patient engagement work for us. And the Patient Clinician Advisory Board has been just amazing. But boy, how powerful will it be to have patients from CCP programs around the country telling the story? And, that's something we haven't touched.
So